Next, we have another common interesting X-ray of a 63-year-old female who came with acute onset of breathlessness. She's a known case of coronary artery disease on medication since last 6 years. On auscultation, there was bilateral fine basal crepes. On auscultation, this is her first X-ray. What does her X-ray show? What are the other conditions with this similar appearances you can think of? What do you think are the mechanism behind this bat wing appearance? What are the differential diagnoses you can think of in reversed bat wing appearance? And what are the other signs of CCF you can think of? We also have shown a follow-up X-ray here. Next, we had a small child, a 2-year-old girl who was brought to the emergency with alleged history of having swallowed a gold coin while playing. On examination, the child was active and alert. Auscultation findings were normal. Systemic examination was normal. An X-ray chest was taken. An X-ray was taken along with the abdomen also. What does the X-ray show? How will you proceed in this case? And what are the complications you can think of? Next, we had a 70-year-old female who presented with complaints of tiredness and reduced oral intake. On examination, pallor was present, and her abdomen examination revealed a massive hepatosplenomegaly. With this history, what will be your clinical diagnosis? How will you proceed to evaluate her further? Other than the regular evaluation, a bone marrow biopsy was also done for her, and a fluorescent in situ hybridization study was done for the patient. And what do these findings in this test show us here? With these findings, how will you treat this patient? Next, we had a 10-month-old child who was brought by the parents with complaints of dysphagia for both solids as well as liquids. They also gave a history of regurgitation of food. On examination, the child was conscious, oriented, vitals were stable, systemic examination was normal. How will you evaluate this patient? Here we have shown an image here. What does this image show you? With the findings in this image, what will be your diagnosis? What are the complications of this condition you can think of? And how will you manage this patient? Next, we have an interesting clinical picture of a 58-year-old female who presented to the ER with complaints of dysphagia for the last 3 months, which was slowly progressive, only to solids. On general examination, as you can see, her nails are shown here, which are flat spoon-shaped nails. Tongue was very much inflamed and swollen. Her vitals were stable. Pulse rate was 107 per minute. Systemic examination was normal. With these clinical findings, what will be your diagnosis? Her UGA scopy picture is shown here. What does her UGA scopy show? What is that syndrome you can think of? And how will you proceed to manage this patient? Next, we have another clinical picture of a 54-year-old female, a male who came to the OPD with complaints of palpitation, exertional angina, and generalized fatigability since 1 month. We have a clinical photo here. Can you spot the diagnosis? How will you evaluate him? What are the features of this disease and how will you manage? Next, we had a 40-year-old male who presented with exertional breathlessness and palpitation for the past 2 days. On examination, his BP was 130/70, pulse rate was 112 per minute, saturation was 92 on room air. He was alert. An ECG was taken for the patient. What do you think are the findings in this ECG? How will you evaluate this patient? What do you think could be the echo finding for this patient? A CT pulmonary angio was done for this patient. The picture is shown here. And what do you think are the findings in this? With this, what will be your final diagnosis and how will you manage this patient? Next, we had a 60-year-old male, a known case of rheumatic heart disease, who came with weakness of left side of the body for the history of for the past within 24 hours. On examination, he was conscious, oriented, he was afebrile, his pulse rate was 121, irregular. On auscultation, S1, S2 was heard, mid-diastolic murmur was heard in the mitral area. A CNS examination showed a plantar was extensor on the left side, power on the left side on the upper and lower limb was only 3/5. His deep tendon reflexes were also exaggerated. With this clinical history, what do you think will be your clinical diagnosis? What could be the etiology of this condition? How will you evaluate him further? An MRA was also done for the patient. The picture is shown here. What does the MRA show? How will you proceed to manage this case? Thank you. So as participants and delegates are pondering over the answers for the quiz questions, we shall now start our meeting as the prayer as everything starts with the Almighty. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I may rely on thee. SAH prayer. Almighty Lord, the source of pink health, we submit our heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Arulraj hospitals with all the doctors and staff. Let them shine up in their efforts to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for this health services to create the healthy longevity for healthy citizen and healthy, vibrant India. Thank you. We shall now start our CME of today. And the first talk for this evening will be on the eye for the clinicians, which will be presented by Dr. Ramya, our consultant ophthalmologist. Over to you, ma'am.
Yeah. Good evening.
Welcome, ma'am. Good evening, ma'am. Ma'am, you can share your slides.
Yeah, yes, ma'am. Just a minute.
Yeah.
Good evening, all. I'm Dr. Ramya. Today, I'm going to present the common eye diseases in the eye. Common eye diseases in eye. First thing is refractory error, diabetic retinopathy, uveitis, cataract, age-related macular degeneration, glaucoma, amblyopia, and conjunctivitis. First, we are going to see conjunctivitis. There are three types of conjunctivitis. Healthy eyes look like this. What about in the viral? Corneal involvement will be there, like superficial punctate keratitis. In bacterial conjunctivitis, discharges will be there, watery as well as sticking of the eyes will be there. What happened in allergic conjunctivitis? Lid edema, papillae will be there, limbal reaction. Depends upon severity, we treat the patients. If patients with allergic conjunctivitis, mild papillae is there, we start with antihistamine along with lubricant. If the patient have limbal reaction, we start with steroid also. What happened in bacterial conjunctivitis? First, we start with mild antibiotic along with lubricating eye drops. If patient have severe conjunctivitis, we switch to the steroid. What happens in viral conditions? We start with antiviral eye drops, lubricating, cold compression, as well as it depends upon patient severity. We'll start with oral tablet also, oral antiviral tablet also. Next is to refractory error. In normal eye, the light is focused on the retina. What happened in hyperopic eye? When the light is fall, the focusing point will be after the light will be fall on the retina. The focusing point will be behind the retina. What happened in myopic? What happened in myopic? Light will fall in front of the retina. What happened in astigmatism? When the light is fall, the focusing point is divided. We'll show the treatment. From age 5 to 15, we'll use eye drops atropine to control the power, to reduce the power also, to avoid contact lens. The patient managed with this. Depends upon power, we'll go for spectacles, eye index as well as bifocal power will be there. And coming to the contact lens, monthly disposable, yearly disposable, multifocal soft contact lens is also available. Coming to the uveitis. Uveitis can be classified as anterior uveitis, intermediate uveitis, as well as posterior uveitis. In anterior chamber, like iridocyclitis and cyclitis and anterior uveitis, and intermediate uveitis means hylitis, cycloiditis, pars planitis. In posterior uveitis means retina or choroid involvement will be there, like retinitis, neuroretinitis, retinochoroiditis, choroiditis, and chorioretinitis. Depends upon the conditions, we treat the patient. If the patients with anterior uveitis, we'll start with systemic as well as oral topical steroid along with cycloplegic eye drops. What happened in intermediate and posterior uveitis? We treat the patients with topical eye drops, cycloplegic, as well as we rule out the systemic causes also, along with oral corticosteroid, prednisolone 1 milligram per kg per day for 60 to 80 milligram per day for 4 weeks. We taper the steroid doses, depends upon the severity of the patients. Next, the chronic complications in diabetic, there are divided into 3 main things: diabetic retinopathy, cataract, as well as glaucoma. In glaucoma, the drainage canal allow the fluid to flow out in normal cases. What happened in the glaucoma cases? The drainage canal block the fluid, builds up in the eye. It leads to pressure damage the optic nerve head. It is irreversible. What is the warning sign of the glaucoma? Redness of the eye, severe red pain will be there, nausea, vomiting, color halos, fatiguability, lacrimation, high intraocular pressure, head pain, sudden loss of vision will be there. What about the symptoms of the patients? Patients sometimes came with blurring of vision, head pain, color halos, pain in the eyebrows, as well as backside headache, high intraocular pressure. We treat the patients depends upon the causes. If there is reduced aqueous secretion, we treat the patient with beta blocker, alpha-2 antagonist, and carbolic inhibitor like acetazolamide, dorzolamide. If the patients having increased secretions is divided into two parts, trabecular outflow as well as increased uveoscleral outflow. If the patient have trabecular outflow is increased, we treat with pilocarpine. If the uveoscleral, we treat with latinoprost and promoplast. Coming to the cataract. Healthy eyes look like this. In glaucomatous eye, there will be intraocular pressure rise along with the cataract, and in cataract, there will be cloudy lenses will be there. If patient diagnosed as cataract, we do intraocular implantation lens, make an incision on superior or temporal, depends upon A scan, emulsified and broke up the cloudy lenses. We implant intraocular lenses. The incision is superior, there is no iris problem. Leave the patients within, it will heal within 1 or 2 days. What are the different type of intraocular lenses? Nowadays, we'll put trifocal, multifocal, toric as well as accommodative lenses also available. Coming to the diabetic retinopathy, if patients with more than 5 years of diabetic retinopathy, we should chronically screen the patients, depends upon the severities, and we find out that the fundus picture as well as OCT and FFA every routine 6 months once will do. Without diabetic retinopathy, early diabetic retinopathy, mild, moderate NPDR, severe NPDR, PDR and neovascularization, PDR with vitreous hemorrhage and PDR with vitreous hemorrhage. Vitreoretinal traction band is also there. Coming to the clinical significant macular edema. Retinal thickening at or within 500 micron from the center of the macula, hard exudate at or within 500 micron from the center of the macula with adjacent retinal thickening, zones of retinal thickening more than 1 diameter part which is within or 2 diameter from the center of the macula. Depends upon the conditions, we treat the patients. If there is mild diabetic macular edema, non-central involvement, observe the patients, we do FFA, OCT. Depends upon the findings, we'll do focal or grid. If not responding patients, will go for anti-VEGF injections. If central involvement, better go for anti-VEGF injections. If PDR cases, there is no diabetic macular edema, better monthly checkup will be there and we do PRP lasers, followed by if patient needed, we'll do anti-VEGF injection. If there is diabetic macular involvement, better go for anti-VEGF treatment, it's first treatment of that. If not responding to this treatment, the patient is having vitreous hemorrhage as well as tractional RD, will do vitrectomy for these patients. Coming to the age-related macular degeneration. Normal retina is looked like this. What happened in the macula as well as fovea is like this. What happened in the wet, leaked blood vessel, blood and fluid, abnormal blood vessels will be there. In dry, drusen's will be there. We find out the patients with, we'll do FFA, OCT for this patient. First, we'll do Amsler, dilated eye and visual acuity test, followed by OCT as a FFA. Depends upon that yearly and intermediate advanced ARMD. Will treat the patient's lifestyle, healthy intake of food, diet and no smoking, alcohol, and monitor the patients. If there is intermediate, we'll do every 3 months follow-up will be there. We'll inject patients with the anti-VEGF injections. If there is neovascularizations in advanced cases, better will do injection anti-VEGF like Lucentis, Macugen is there, Ascendric injection there. Every 3 months, ask the patient to come. We do OCT, and if 250 micron is there, we'll follow the patient. More than 350, we'll do every 3 months once injections. Depends upon that, we'll treat the patients according to the severity of the patients. Thank you.
Thank you, ma'am. That was an excellent and informative talk for us. Thank you so much.
Thank you, ma'am. Anybody
delegates, if you have any questions, ma'am will be happy to take it. As of now, we do not have any questions in the chat box, ma'am. Delegates, you can even post your questions during the next session also. Ma'am will be very happy to take it.
Okay. Madam, can I have a question? I'm Dr. Karna from Chennai.
Yes, ma'am.
Ramesh, what a wonderful presentation on eye outcomes. So some of my OP, even diabetic patients, most of the diabetic patients will have some dry eye syndrome. What's your take home on this, ma'am?
The main thing is this hormonal changes. Chronic diabetic patients have dry eye. The blockage will be there in duct. So we'll treat the patients, depends upon mild, moderate and severe cases. Mild means we'll start with mild lubricating, followed by moderate also we'll treat with, we'll do simmers for patients who's more than 15 mm. We treat with mild antibiotic. Less than 10 means severe dry eye will be there. Along with the antioxidant, like osmega, we'll treat the patients of cyclosporin. For severe dry eye, we treat the cyclosporin eye drops. If severe case depends upon severity, we'll start 4 to 6 times eye drops. That to refresh liquid gel type of eye drops is more penetrations will be there. Along with the antioxidant supplementary there. Every 1 month, ask the patient to come. We'll do Simmer's test for patients and we'll treat the patients according to that.
Okay, ma'am. But there are another question regarding a diabetic patient. Most of the diabetic patients, they cluster with hypertension. See, for hypertension, we prefer only beta one, this one antagonist. But this patient with the glaucoma, they need alpha blockers. In this case, if we combine with this alpha blockers over the eye preparation with the beta one antagonist, is there any problem regarding drug-to-drug interaction with this?
So some patients saying breathlessness. Depends upon patient only we treat. Ask the patient to put eye drops and wait the patient for 1 hour. After that only we send the patients and we follow the patients. If patient complaining of any itchiness as well as lid edema, breathlessness, after come the patient to the OPD, will stop the eye drops. Sir.
Thank you, Ramya madam. I thank respected Arati madam also for giving this opportunity for me. Thank you, madam.
Okay, sir. Thank you.
Thank you, Kannan sir, for your highly informative questions. We've got so many doubts clear today. Ma'am, if we get more questions, we'll let you know, ma'am.
Okay.
Yes, thank you, ma'am. Thank you so much. Since there are no more questions, we shall move on to the second talk, which will be a case discussion for today on inexhaustible pleural effusion, which will be presented by Dr. Basil, our DNB postgraduate. And it will be discussed by Dr. Sundarlingam sir, our senior consultant pulmonologist, sir. Over to you, Basil.
Thank you, ma'am. Today I'm going to present a case of inexhaustible pleural effusion. This is a case of a 48-year-old male patient who is a porter with, by occupation with no known comorbidities and is presented with dry cough and loss of appetite since last 3 months. And he also complains of breathlessness since last 1 week. The patient was admitted at nearby hospital for cough and was treated for pneumonia as inpatient for 1 week, but he was showing no signs of improvement and developed breathlessness even at rest. No history of fever, expectoration, significant weight loss, positional variation, chest pain, pedal edema, orthopnea, or any contacts with TB patients. He was a smoker and used to 10 cigarettes per day for the past 20 years, and he is an occasional alcoholic. Coming to the vitals, BP is 140/90 mmHg in the right arm supine position, and the respiratory rate is 40 beats per minute. Pulse rate is 123 beats per minute with normal volume and regular rhythm, and all peripheral pulsation was equally felt bilaterally. And saturation was 82% in the room air. Coming to the general examination, patient was conscious, oriented, and he was having no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. And it looks cachexic and dyspneic. Coming to the systemic examination, patient was tachypneic and respiratory rate was 40 beats per minute. And deviation of trachea was present to right side and decreased chest movements in the left side. And also on percussion, dullness, dull note on percussion in the right axillary and mammary areas, and stony dullness in the left infraaxillary and infrascapular area were noted. And he was also having decreased breath sounds in the left infraaxillary and infrascapular regions. And bronchial breathing was present in the right axillary area. And also a bilateral basal crux was also present. Now, other system examination was normal, except apical impulse was shifted medially. With this,
sir, you can just unmute yourself, sir.
Dr. Basil, you can just continue. In the end, we will discuss.
Okay, sir. Okay, sir. With this history and examination, we came to a clinical diagnosis of right-sided consolidation and left-sided pleural effusion, most probably due to lobar pneumonia or tuberculosis or any lung malignancy. Coming to the lab investigations, he was having HB of 12.4 and the total counts was showing neutrophilic leukocytosis, and platelet and kidney function test was normal, and ESR and CRP was mildly elevated. And sputum AFB and CB was done, and it was negative. And ECG was normal, and echo was showing EF of 60% with mild TR and mild pulmonary artery hypertension. Chest X-rays was taken, and the first X-ray was showing right middle lobe consolidation along with left-sided massive pleural effusion. And after tapping, left lower lobe consolidation was also visible along with the right middle lobe consolidation and effusion. So pleural fluid analysis was done, and it showed color was reddish and hemorrhagic effusion. And analysis showed it was a exudative effusion with a protein of 5.0. And cytology and cell block was done, and it was negative for malignant cells. And also gram stain and AFP was also negative. And subsequently, a CT chest was taken, and it showed multiple soft tissue densities. It was regular round lesions in both length fields, and largest was measuring 7.7 into 7.5 centimeter with multiple enlarged mediastinal lymph nodes. Course in the hospital. Initially, patient was treated as a case of lobar consolidation with left-sided cinnamonic effusion, but he did not show any response to the treatment, and was later he developed bilateral pleural effusion. Diagnostic and therapeutic thoracosynthesis was done and showed hemorrhagic effusion. Patient was having recurrent massive effusion as was tapped multiple times. Analysis was negative for TB and malignancy. And since patient was not willing for bronchoscopy, a CT-guided biopsy was taken, which showed a squamous cell carcinoma. And histopathological examination showed squamous cell carcinoma of the lungs. And with that, a final diagnosis, squamous cell carcinoma lung with recurrent pleural effusions was made. And patient was treated with IV antibiotics and therapeutic pleural tapping. And he was advised chemotherapy, but he was not affordable, and hence referred to government hospital for further management.
Good evening, sir, and good evening all. So this case was well presented by Dr. Basil. So initially, this patient, after the pleural tapping, which was done as a diagnostic, but we did as a therapeutic, so that his symptoms will be relieved. So the initial pleural fluid analysis showed that an exudative pleural effusion with the hemorrhagic background. So most of the time, that is around 30% of TB effusion can also present as hemorrhagic. But the hemorrhagic pleural effusion first we came to mind was a malignancy. So to rule out malignancy, we did 2 times that cell block analysis from the cytology, which turned out to be negative. So again, this patient history also, he is a potter for years together. So this with the of an occupational potter exposed to silica and silico TB also suspected. But the sputum, both times with the smear as well as CBNet were negative. So the picture were both of TB and malignancy, but we couldn't clinch the diagnosis through our cytology or sputum examination. So the thing here is after the bilateral lesion, that is consolidation occurring right side and left side, initially the patient presented as a pleural effusion in the left, which was massive, and second, right also he developed. So ultimately, there's CT-gated biopsy clinched the diagnosis as squamous cell carcinoma. So in malignancy, malignant effusion, we have little choice only. When a malignant pleural effusion diagnosed, the lifespan is only from 4 months to 12 months. So it is to relieve the patient's symptom, we have planned for next pleural disease and same time chemotherapy because one of this patient went for GH. The one thing is before doing a pleural disease, we have planned to rule out whether the relieving the pleural fluid from the space will decrease the patient's symptom. So for this patient, this was very well achieved. Second thing, we should also confirm that whether we are able to approximate the visceral parietal pleura, because both the pleura has to be adjacent so that our pleural disease will take up. So 2 steps. One thing, aspiration, whether there is an improvement in the symptoms of the patient, there is breathlessness coming down. Second thing is whether the lung is expansion. This will help us in selecting patients for pleural disease. And coming to the cytology, so this patient, for this enormous mass lesion and pleural fluid which is hemorrhagic, we couldn't find the cytologically the cells for malignant cells. The literature also says that in cytology, most of the time in adenocarcinoma or a cancer of an ovarian tumor, the cytological reports matches up to 60%. We can pick up in 60% of cases. But in squamous cell carcinoma, it is below 20%. So for this patient, our pleural, CT-guided biopsy was the tool which pinpointed the diagnosis. Thank you, sir. Thank you, team SAH, for giving me this opportunity.
Coming to the discussion, lung cancer is the most diagnosed and deadliest cancer worldwide. 2.2 million cases in 2020, resulting in 1.8 million deaths. The average age at diagnosis is about 70 years, and the average age at death is 72 years. Prior to the advancement of cigarette smoking in the 20th century, lung cancer was a rare disease. And in 1950s and 60s, increasing evidence linked the lung cancer and tobacco use, culminating in declarations by most large national health bodies discouraging tobacco use. The two general types of lung cancer include small cell lung cancer and non-small cell lung cancer. Small cell lung cancer occurs almost exclusively in heavy smokers and is less common than non-small cell cancer. And non-small cell lung cancer is an umbrella term used for several types of lung cancers. It includes squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. Coming to the paraneoplastic syndromes associated with lung cancer. First one is hypercalcemia. In patients with small cell squamous cell carcinoma, which results from tumor producing parathyroid hormone related protein, or because of extensive bone mets that cause production of osteoclast activating factors. And the second paraneoplastic syndrome is SIADH, that is syndrome of inappropriate antidiuretic hormone secretion. The third one is the finger clubbing with or without a hypertrophic pulmonary osteoarthropathy. The next major paraneoplastic syndrome is Tracer's syndrome, that is hypercoagulability with migratory thrombophlebitis. And next one is Lambert-Eaton myasthenia. And next is Cushing syndrome, or can be associated with various neurological syndromes. The neurological syndromes include neuropathies, encephalopathies, encephalitis, myelopathies, and cerebellar disease. Mechanism of neuromuscular syndrome involve tumor expression of autoantigens with production of autoantibodies. But the cause of most of other syndrome is unknown. And finally, why this case was presented. The patient was presented with bilateral lung lesions with pleural effusion and mediastinal shift to right side. And he was not responding to antibiotics and anti-tuberculous therapies. And sputum examination and pleural fluid analysis was negative for both TB and malignancy. And finally, CT-guided biopsy proved the diagnosis. Take-home message: recurrent pleural effusions first think malignancy, and CT-guided biopsy is always decisive. Thank you, everyone.
Thank you, Basil. And we thank Dr. Sundarlingam sir also. That was an interesting case discussion we had today. Delegates, you can unmute yourself and ask your questions if you have any questions. As of now, we don't have any questions as such, sir, in the chat box. So if you get any questions, we'll let you know, sir. Karan sir, do you have any questions?
We need comments from our Professor Arulraj sir regarding this case presentation.
He will be giving the comments, sir, soon.
Yes.
Next. So we thank both the speakers, Basil and Dr. Sundarlingam sir, for the excellent case discussion. So we shall now move to the last agenda for today, which will be our chairman, sir. We request him to give the concluding remarks about the two cases and also discuss the answers to the clinical album. Over to you, sir.
Thank you, Aarti. And my great welcome to all the faculties and the participants for our monthly clinical pathological conference. Today we had very interesting case presentations, and very important people are also participating. I must thank really Kannan for being actively involved here. I am sure next time we will ask him to present a case also. being digital from anywhere. We have had people presenting from UK also. Therefore, I mean, it is not a big issue. Now, first of all, regarding the two cases, the first case, I should really appreciate the efforts taken by Dr. Ramya to show the importance of eye to the clinicians. See, from the ophthalmologist point of view, they are doing an excellent job. But for a practicing doctor, what is the importance? He has very nicely said, right, from conjunctivitis, cataract, and then, the increase intraocular pressure, all those things. I am always passionate about eye as one of the focusing point for the clinical medicine or clinicians. We see anemia in eye, we see jaundice in eye. In this sclerocorneal junction, we see the KF ring, and there is a cornea, there is a lesion, or there is sclera, there is a lesion, there is a lens, there is a lesion, or there can be a lesion in the vessel. I used to say, the fundoscopy gives an opportunity to the clinician to have a look at the blood vessels and say how much the blood vessel is affected. My chief KS used to say, when one retinal vessel is involved, 2 coronaries are gone and 4 cerebrals are gone. That's the important of it. And the retina and all these things have a clinical implication, and a bleeding in the retina can be a blood sclerosis or an injury. He has done it so well. I am sure she has done a great job to the practicing clinicians.
Thank you, sir.
Our second case is an interesting.
Sir.
Our second case is an interesting case. Thank you, Ramya. We expect a lot from you in the future meetings also.
Thank you, sir. Thank you.
Coming to the second case from our institution, see, it's a very important clinical, scenario. See, the first point here is a smoker has got a bilateral lung lesion. On the right side, there is a consolidation. On the left side, there is a fluid. And the man has got, breathless, and that is the first point. Second point, the left side, we aspirated and showed a hemorrhagic pleural effusion. That is the second important point. The third important point is inexhaustible effusion. I am always very much fond of this terminology, inexhaustible. The people can also call it as a recurrent pleural effusion, but I used to call it, you are not able to clear it. Even after repeated aspiration, that inexhaustible effusion, that has got a background. All these three things, bilateral lesion, hemorrhagic pleural effusion, and an inexhaustible effusion, always should make you think of 2 important things. One is tuberculosis, second is malignancy. And you will have to always keep this in mind before, you start treating the patient. Of course, things have gone well, repeated aspiration, thanks to Dr. Sundarlingam for his clinical support. And then we started an anti-tuberculosis therapy with steroids also. Still it was coming up. And the patient was not ready for a bronchoscope, or was not ready for a pleural aspiration. A pleural biopsy. We don't have any facility for a thoracoscopy. Then I saw a shadow in the lung. Then I suggested, why don't we go for a CT guided lung biopsy that gave the diagnosis as a small cell lung carcinoma. It is very important. Always you must continue your struggle. Persuasion. Persuasion is very, very, very important. Then you will make out the diagnosis. What is the treatment that the science will tell us? And the patient accepts or not, it is fine. Our important duty is to make a diagnosis. Hemorrhagic effusion, bilateral lesion. One side it is shown as a consolidation clinically, radiologically. Another side is a pleural effusion clinically, radiologically. Then these lesions always should make you think that we are dealing with a difficult case, most probably malignancy to be confirmed. I am thankful to our postgraduates for the excellent work they have done under the leadership of Dr. Sundarlingam. Sure, we will do more. Now coming to the clinical album, the first one is a very interesting one. You change it. It is a very interesting problem. If you see that somebody has come with some breathlessness, an 80-year-old male. But what is the important here is this patient has got a pulsus paradoxus clinically. Very important. Very important. Always that gives you a clue. and the jugular venous pressure is raised, but non-pulsatile. That itself should immediately, these two things make you to think what? It is a pericardial effusion. There is no other condition wherein these two things are, enclosed. See the ECG, you have pulses alternance and electrical alternance is also there. That is because of the, the heart swinging inside the fluid in the pericardium. There will be diminished heart sounds, there may one or two murmurs or a pericardial drum, or the fluids can also, we can have an enlarged cardiac shadow, all those things are there. X-ray is very classical. X-ray always says the Sothumutan solvo. That is the base is small, apex is high. That is very classical of a pericardial effusion with lung fields. When there is a cardiomegaly with the fluid in the lung, it is cardiac failure. When there is cardiomegaly with clear lung field, it is pericardial effusion, unless proved otherwise. Echo is the gold standard. You put in a probe on the chest, it will tell you there is a fluid or not. How much of fluid is there? Mild, moderate, severe or tamponade or not? And what? And there are any additions inside. To some extent, the type of fluid also. A clear fluid or fluid with sediments always says it is exudate. There can be tumorous things also. Can tell you that it is tumor. Now in this patient, it is a moderate pericardial effusion of exudated type, as aspirated, ADA was positive. Commonest cause of an exudative pericardial effusion is tuberculosis. We should always remember that. Next. Here it's a very interesting, clinical situation. An upper limb pain. Upper limb pain can be on the outer side or inner side, C5, C6 or C81. When it is on the outer side, we always think it could be a cervical rib or cervical spondylosis. When it is inside, you will think whether it is a vascular or a neural. If it is neural, usually you will have to consider a cervical rib. Take an X-ray chest, carefully observe, you will see the classical, cervical rib on the right side. Accent test, we can always do that. But when there is an inner side, C81, and there is no vascular deficit, always is a neurological cause of upper limb pain. Most probably it is cervical rib. Clinically, you should be able to make a diagnosis, and sometimes with physiotherapy or with surgical excision, patient is totally relieved. Yes, next. Next is a very interesting thing as we discuss now about the pericardial effusion. Cardiomegaly with fluids in the lung, it is always cardiac failure. Cardiomegaly with clear lung fields, it is pericardial effusion. Here you see this X-ray, first X-ray, we have got a cardiomegaly with central opacity. Central opacity with peripherally the venous loops are seen. A prominent venous upper lobar veins that is classically described as a bat swing appearance. There can be a reverse bat swing also. Peripherally, there can be fluid that always thinks, that always makes us to think carcinoma or sarcoid or radiation pneumonitis. Central opacity with upper lobar veins prominent, always think it is a left heart failure, a pulmonary edema. With appropriate treatment, it improves well, as shown in the second X-ray. Yeah. Next one. See, this is very interesting. We have seen many times. Children or adult, they swallow, children swallow coin or rings, adults swallow their teeth, and it's a foreign body in the esophagus. What is the treatment? Has to be removed. Earlier, we have to open the chest or open the abdomen. Now, thanks to our gastroenterologists with interventional endoscopies, they are able to remove it safely without any damage to the internal organs. Also, after 2 hours, they take food and go. Here is a, ring which has been retrieved by our gastroenterologist, thanks to him. Interventional endoscopy is always rewarded. Anywhere intervention, vascular intervention, GI intervention, urogenital intervention, neuro intervention, anywhere intervention is the order of the day. If you want to give results to your patient, you will have to be very much aware and capable of intervening. Yeah, next one. See, this is a very interesting problem. In anemias, We always make out anemia as our Ramya said. You see the eye, you see the palmar crease, and you see the tongue, oral mucosa. Make a diagnosis of clinical diagnosis anemia. You just evaluate by the hemogram, try to make out what is the type of anemia to some extent. But the key or the final court of appeal is the bone marrow. Bone marrow, either it could be done in the sternum or it could be in the done in the pelvic bone. But if you want to do a good sample, a pelvic, this iliac crust is good. Here an iliac crust is being biopsied for a 70-year-old man for an anemia. It gives us a diagnosis, myelodysplastic syndrome. MDS, it usually needs a immunomodulator or it needs a bone marrow transplant. This elderly gentleman is thinking about it. Now the message here is bone marrow is essential to make an etiological diagnosis of anemia. Next, please. Our boys must be a little more smart and fast. And here is a dysphagia. See, dysphagia, when we think, we always think two common etiologies. One is malignancy, another is achalasia giardia. Malignancy, all of us know it's a tumor. Achalasia is a failure to relax. And you will have, this is a benign condition, that is a serious condition. We will have to differentiate. The simple test that can differentiate both is a barium swallow. When you take a barium swallow, shows a rat tail appearance, classical of carcinoma. When it shows a parrot beak appearance, it makes a diagnosis of achalasia, which our interventional gastroenterologist will relieve it very nicely. Whereas a CA means needs to go for biopsy and further management. A bird's beak appearance is always in favor of achalasia giardia. That's a message. Yeah, next. This is a very important thing here. A common syndrome that we have been talking about. It's a Plummer-Vinson syndrome. It has a combination of an iron deficiency anemia, and eat well, and then anemia, everything goes well. Anemia and dysphagia, always think Plummer-Vinson syndrome. Yes. Here, if you see very excellent diagnosis. You see his eyes are prominent. There is a definition for that. When you are able to see the sclerocorneal junction as the patient is looking straight, this patient has got a proptosis. In the lateral view, as shown here, will always tell you he has got a proptosis or not. And you can take multiple views, there is a proptosis. The commonest cause for a bilateral proptosis, all of us must remember, is thyroid abnormality, a thyroid hyperfunctioning, that we should always know that, and immediately look at the neck, there will be a thyrocardiac problem. There will be a thyroid enlargement with or without a toxicity. Therefore, we should remember that. And always this clinical diagnosis is very important. You further evaluate that and either go for medical therapy or surgical therapy. Yes. See, this is a very interesting and clinical picture. Many times now we are able to see. Many times we are able to see that patients come to us with acute chest pain and breathlessness. The immediate diagnosis that we think about it is it's not. You have done the enzymes and you have done the clinical examination, ECG, it is not. Always think in your mind that it could be a pulmonary thromboembolism. And simple, easy clues Q3, T3, H3. Always when it is there, you have a doubt. That will always guide you. The final court of appeal is a pulmonary angiography. This pulmonary angiography will show you as marked here the thrombus immediately heparinizing. Sometimes you may be able to do with thrombolysis, may need a thrombus extraction and a long-term anticoagulants. Always look for the source of embolus. Look for the source for embolus. It will usually be a thrombophlebitis in the leg. Yes. Yes. I think this is a very interesting problem. And this particular, male has a rheumatic heart disease. Long-term on a penicillin resistant, he came to hemiplegia on the left side. And when the metal stenosis hemiplegia, the cause effect is very easily diagnosed. That is the diagnosis. And immediately you evaluate the cardiac side, look for some thrombus. Most of the times this left atrium or appendix may be empty because already the bullet has been fired. Therefore, there is no bullet, no clot, and you may miss it, doesn't matter. But an irregular rhythm, and you confirm the vessel through which this embolus has gone, and the damage that has been done to the brain, we are able to make it out. Therefore, this is a clinical entity. When there is an atrial fibrillation with rheumatic heart disease, hemiplegia, the cause effect is very much confirmed. One important thing is all these people need anticoagulant, not for 6 months or 1 month, 1 year, lifelong. And never try to bring these atrial fibrillation to sinus rhythm. There causes multiple emboli. Always try to keep the left ventricular rate low. That is enough. The functions will be okay with anticoagulants. We'll be able to do best. Next one. I think we have done it. Yeah. Now, it is an excellent clinical exercise today. I should thank all our team and all the participants for their, very interesting, queries and observations and participation. We will see all of you in the next CPC in the next month. Good night to all of you. Thank you. Thank you.
Thank you, sir, for your valuable clinical discussion. We thank all our colleagues once again, and let's all meet again next month with a few more interesting clinical discussions. Till then, stay safe and healthy. Good night to one and all.
Thank you, madam. Good night, madam. Thank you, sir. Good night, sir.
Good night, sir. Thank you, Ramya ma'am. Thank you so much.
ma'am. Good night, ma'am. Okay, bye.
And good night, ma'am. Thank you so much. Romba nalla irundhuchu, ma'am. Thank you.
Thank you.
Sundarlingam sir, thank you so much.
Thank you, ma'am. Thank you, ma'am.
Thank you, sir. Thank you. நான் இங்க காணமே நீங்க பாத்துட்டு இருந்தோம்.
மேடம் மாட்டிக்கிட்டேன்.
சரி பரவாயில்ல சார், நோ ப்ராப்ளம். நெட் நல்லா வந்துருச்சு. தேங்க்யூ. தேங்க்யூ சார். தேங்க்யூ. Santosh, you can close the meeting.
Yes.
Okay, Thambi.